Ana María Nubia tiene el enlace como panelista.
Ya confirmo, voy a escribirle y te cuento, Ricardo, que en teoría sí, pero no la veo conectada.
Sé que ya estamos listos para el streaming. Solo esperemos entonces un minuto. Bueno, Nubia me dice que ya está conectada. Perfecto. Iniciamos en punto. Doctor Olarte, el auditorio es todo suyo.
Bueno, buenas noches y bienvenidos a esta clausura de nuestro programa de creación de centros de prevención secundaria de fracturas de fragilidad, el cual hemos desarrollado en este último trimestre. Primero, pues, felicitarlos por haber llegado hasta este punto. Agradecerles infinitamente que ustedes se hayan conectado y hayan tenido la paciencia para todos los módulos que desarrollamos, los cuales les van a dar herramientas para desarrollar. Para finalizar y para complementar, tenemos hoy una agenda muy interesante en donde nuestra principal actividad va a ser la conferencia del Dr. Kozla, que lo vamos a presentar más adelante. Vamos a tener entonces a la conferencia del Dr. Kozla y aquí en este momento quiero que ustedes todos me sigan en la pantalla porque la conferencia tiene traducción. Van a ver ustedes que en la barra inferior hay un icono que dice interpretación. Este icono de interpretación lo pueden cliquear y va a estar para la traducción simultánea. Ustedes hacen clic en español para oír la conferencia del Dr. Kozla. Entonces, después de esto vamos a tener algunas palabras de las personas que hemos formado parte del curso, de Daniela Abril en representación de las directivas de la Facultad de los Andes, de Nubia Hernández en representación de Amgen, de Andrés Livos en representación de los estudiantes del curso y de Ana Milena en representación de nosotros los coordinadores. Vamos a presentar el diploma del curso y cerraremos el evento. Entonces, sin más, le doy la palabra a Ricardo Peña para que nos haga el favor de...
Muy buenas tardes a todos. Bienvenidos al cierre de nuestro curso de fracturas por fragilidad. Me presento, yo soy Ricardo Peña, profesor de la Facultad de Medicina de la Universidad de los Andes, farmacólogo y tengo un laboratorio que trabaja temas de investigación en farmacología del envejecimiento. Este es un campo de investigación que ha explotado durante las últimas 2 décadas y uno de los centros líderes en investigación en envejecimiento, tanto a nivel básico biomédico como a nivel clínico, es la Clínica Mayo. Por eso para nosotros es un gran privilegio y un gran honor contar en el día de hoy con la presencia del doctor Sandeep Khosla. El doctor Sandeep Khosla es médico del programa en Ciencias de la Salud y Tecnología de la Facultad de Medicina de la Universidad de Harvard y el MIT. Es médico internista del Hospital General de Massachusetts, donde también realizó su fellowship clínico y de investigación en endocrinología. Luego de completar su entrenamiento clínico, el doctor Khosla se vinculó como profesor de la Clínica Mayo en Rochester, Minnesota. En la actualidad él está vinculado a la sección de geriatría y a la división de endocrinología del Departamento de Medicina Interna. Además, el doctor Khosla es profesor de los departamentos de Fisiología e Ingeniería Biomédica. En la Clínica Mayo, el doctor Khosla recibió múltiples reconocimientos y en la actualidad es el Francis Shocker and Nathan Landau Research Professor y es investigador distinguido de la Fundación Mayo. Su trabajo en biología del sistema osteomuscular nos ha permitido comprender mejor, primero, la homeostasis del calcio y la mineralización ósea durante el envejecimiento. Además, su investigación también ha iluminado el camino para entender el rol de las hormonas esteroideas en el control de metabolismo óseo y el impacto que tienen algunas enfermedades como la diabetes en la mineralización de los huesos. El doctor Kozla cuenta con más de 400 publicaciones indexadas y ha recibido numerosos premios y reconocimientos por su trabajo en investigación. Dentro de estos premios destacamos los premios por investigación sobresaliente de la Sociedad Americana de Investigación en Hueso y Minerales, la Sociedad de Endocrinología y la Fundación Novo Nordisk. Además, él recibió el Premio de Fronteras en la Ciencia de la Asociación Americana de Endocrinólogos Clínicos. Así que, por favor, acompáñeme a recibir al doctor Kozla con un gran aplauso. Muchas gracias por estar aquí, doctor Kozla.
Thank you. It's a real pleasure to be here. I'm just going to bring up my slides. So in the next 30 minutes or so, I'm going to talk about a new area that's gaining a lot of interest, namely cellular senescence, and the potential to use, to better understand this pathway and to use it to treat both age-related osteoporosis and frailty. So I have no financial disclosures relevant to the talk. So over the past 25 years, as you all know, there has been remarkable progress in the treatment of osteoporosis. Back in the late 80s, for example, we basically could offer estrogen to women and calcium and vitamin D to men. But now, although estrogen is rarely used, it's still available. We have raloxifene, 4 different bisphosphonates, teriparatide, abaloparatide, denosumab, and also romosozumab. Unfortunately, odanacatab, which is a cathepsin K inhibitor, was stopped in development due to side effects. But we do have quite a few drugs to treat osteoporosis. And one of the interesting things is that these early drugs really kind of came out of almost by chance and opportunistic. But the newer drugs, for example, denosumab and romosozumab, really have been driven by advances in fundamental science and fundamental bone biology. Romosozumab, for example, came from understanding a rare genetic bone disease that led to dense bones, and that eventually led to the sclerostin antibody. So I think osteoporosis is a great example of how investing in the fundamental discovery science can, in fact, translate into novel therapeutics. So given all these drugs, why do we need new approaches to treat osteoporosis? So first of all, as this audience knows, it's a huge public health problem. So for example, the number of women who will experience a fracture in 1 year, in fact, exceeds the combined number of women who will experience incident breast cancer, myocardial infarction, or stroke across all ethnic groups. So there's a large number of women that experience fractures around the world. There are also important gaps in our drug arsenal. So as you know, because of the fear of rare side effects, in particular osteonecrosis of the jaw and atypical femur fractures, there's a need for newer agents that lack these complications. We also don't know if the bisphosphonates are effective beyond 5 years. And so we really don't have the perfect drug in terms of inhibiting bone resorption. There's also a need for new drugs to build bone, the so-called anabolic drugs. And the main reason for this is that with all of the currently available drugs that stimulate bone formation, the ability to stimulate bone formation is limited to 6 to 9 months. So we really can't continue to increase bone mass indefinitely with these drugs. But beyond these issues, there's a fundamental problem for current treatments for osteoporosis and, in fact, other chronic diseases of aging. And that main problem is that as we get older, we get multiple diseases, and current treatment strategies for all of these chronic age-related morbidities are disease-specific. So for example, to prevent heart disease, a patient will take a statin and a drug to lower blood pressure. For the treatment of diabetes, they'll take a diabetes drug, and then a bisphosphonate for osteoporosis. So very rapidly, the list of drugs that a patient is on grows fairly quickly. And in fact, it's estimated that almost 70% of older adults take 5 or more medications. And of course, this leads to side effects, adverse drug reactions, and non-compliance. And certainly in most clinics, the primary care physician who's very busy is often dealing with more pressing problems that they think are more pressing than osteoporosis. They may be more concerned about the blood pressure of 160, and the spine T-score of -2.7 remains untreated for many years. So this is a problem common to all of the diseases of aging. Now, instead of thinking of osteoporosis in isolation, as I also used to do in the past, I think as we study disorders of aging, it's important to think about osteoporosis in the context of all of the other diseases that we all get as we get older, including diabetes, dementia, vascular disease, macular degeneration, and so forth. So what's important is that all of these diseases are driven fundamentally by getting older or by aging. And this has led to this geroscience hypothesis, which says that because these diseases are all related to aging, that if you manipulated fundamental aging mechanisms that's causing aging in every tissue, that would then delay the appearance or severity of multiple diseases, because these diseases share the same underlying risk factor, which is aging. So there's growing evidence to support this idea. Now, aging, it turns out, is driven by at least 9 fundamental mechanisms, and these are listed here, and I won't go through each of them, but you're probably familiar with some of them, such as attrition of telomeres or mitochondrial dysfunction. We at Mayo and now many other groups are particularly interested in cellular senescence, and that's what I'm going to talk about because the thought is that by targeting this mechanism of aging, you could help prevent osteoporosis, frailty, heart disease, many other conditions. But for the talk this afternoon, I'm going to primarily focus on osteoporosis and to some extent on frailty. So cellular senescence is not new. You might remember it from medical school. It was actually described back in 1961 by Hayflick. It's a cell fate that involves replicative arrest. There's activation of tumor suppressor genes and a number of other changes that occur in senescent cells. And this is Dr. Hayflick who originally described it, because when he cultured mammalian cells for a long time, they would grow and then eventually they stopped growing and then just sat in the tissue culture, and he termed this phase senescence. Now, it's now clear that senescence also occurs not just in culture, but in animals and in humans. So the idea is that as you go from young age to old age, you get an accumulation of these senescent cells, these aging cells in the tissues, and they secrete the senescence-associated secretory phenotype, or SASP, which is highly inflammatory. It has a lot of inflammatory cytokines, and as these cells accumulate with aging, they cause tissue dysfunction because of the inflammation that they cause. And the hypothesis is that if you targeted these cells, you could rejuvenate aged tissues. Now, over the past 10, 15 years, the mechanisms driving senescence have been worked out by many different laboratories. And the general pathway is that when a cell undergoes damage due to DNA damage or various other stresses in the cell that occur as we get older, there's activation of 2 key genes, P16 and P21. These are key genes that drive a cell into the senescence growth-arrested state. These cells, it turns out, also upregulate a number of pathways that confer resistance to death of the cell. So it's very hard to kill this cell because they have activation of these so-called anti-apoptotic pathways, or SCAPs. There's also a cellular response to the DNA damage, which activates this inflammation pathway and leads eventually to the production of the SASP, which is the secret senescence-associated secretory phenotype. These are the pro-inflammatory cytokines like IL-6, IL-1 alpha, and IL-1 beta. All of these cytokines cause tissue dysfunction and inflammation. Now, it turns out there's two different ways you can attack these bad senescent cells. One is with this class of drugs that I'll talk about, which are senolytics. And senolytics target these pathways that are present in the senescent cells that make them resistant to death or resistant to apoptosis. So the hope is that with these senolytic drugs, you can kill the senescent cell without affecting normal cells. The other approach is the so-called xenomorphic approach. And one example of a xenomorphic agent are these JAK inhibitors that are used for rheumatoid arthritis and other conditions. These JAK inhibitors inhibit the secretion of the SASP, but they don't actually kill the senescent cell. So P16 is a gene, as I mentioned, that's a key driver of cell senescence. And a number of years ago, we asked whether there was evidence for senescence in aging bone. So these are mice, female mice and male mice, and you can see starting at about age 18 months of age in a mouse, which is probably about 70 years of age in a human, you can see an increase in senescent cells in bone as measured by expression of this gene. This is in females and in males. We then actually in this work looked at different cell populations, osteoblast populations and the hematopoietic populations. And you can see in virtually all of the cells that we examined within the bone microenvironment, there was an increase in the mice in this senescence marker of P16. The other important senescence marker is P21, and that went up mostly in the osteocytes in bone. Now, there are also other ways to measure senescence. One is this senescence-associated distension of satellites. This is a cell in the bone, and it develops this abnormal DNA that you can image. And you can see when you do that, you find that in bones from old mice, there's about a 3- to 4-fold increase in the number of senescent cells as measured using this technique. And there's another technique that can be used, the so-called TAF assay. Again, I won't go into the details, but the bottom line is that in old mice, there are a larger number of osteocytes that are positive for senescence using this particular measurement. And especially if you look at more than 3 of these abnormal TAF signals for osteocyte, there's a significant increase. Now, we also measured the cytokines using quantitative PCR, and you can see in old mice, there's an upregulation of many of these inflammatory cytokines, which is this senescence-associated secretory phenotype. And especially for those of you that might be rheumatologists, you know, some of these like IL-6, IL-1 alpha, beta are probably quite familiar to you, but they cause inflammation and tissue damage. In the bone marrow, in addition to the osteocytes in the bone, the cells that were also highly expressing this inflammatory phenotype in mice were these myeloid cells. And you can see this marked increase in this SASP in the myeloid cells in the bone microenvironment. Now, we also looked at humans. These are small needle biopsies that we get from women from the iliac crest. This is a micro CT showing the bone, and then in between is the marrow. And you can see, similar to mice, when we look at older women as compared to young women, there's an increase in this P16 and P21. Both of these, as I mentioned, are important markers for cell senescence. And then when we measure the SASP or the inflammation, again, there are many of these markers that go up in the biopsies from the older women. So what these studies told us is that with aging, there's an accumulation in the bone microenvironment of senescent osteocytes, as well as other senescent cells, in particular myeloid cells in the bone microenvironment. These cells have high expression of multiple of these inflammatory SAS markers, which based on what we know about these markers would lead to an inhibition of bone formation and an increase in bone resorption and ultimately to bone loss. Findings similar to us have been reported by other groups. This is from the group at Arkansas, where they also reported basically very similar increases in senescence markers in old as compared to young mice. And they also found evidence of senescence in stem cells, in osteoprogenitor cells in the bone microenvironment. So in order to prove that the senescent cells were important, we took advantage of this genetic approach. And basically, it's a very simple approach. It's a mouse that is expressing this gene. It takes the P16 promoter, which is upregulated in senescent cells, and it basically drives a suicide gene. So when we expose these mice to this drug, it causes activation of this enzyme that causes death. But the death is specifically of senescent cells because they're the ones that are expressing high levels of this gene. And so this mouse model allows for elimination genetically of senescent cells when you give this particular drug and cause dimerization of this protein. And you can see this is from the epididymal fat from an old mouse, and the blue stain here shows senescent cells in this mouse. But when we treat the mouse with this drug, these senescent cells are killed, and this tissue looks like young tissue. So we took these mice, and at age 20 months, which is probably about age 75 years or 80 years in humans, and treated them for 4 months, either with a vehicle or with the drug. And we could show that in fat tissue, there was a reduction in senescent cells as measured by the P16 gene. And in bone also, you can see these senescent osteocytes that were reduced. So basically using this genetic approach in these very special mice, when we give this drug, we can reduce the number of senescent cells or these bad cells. So the question is that if you do that, can you prevent bone loss with aging in these mice? And the answer is yes. So this is a micro CT of the spine from a mouse that's given vehicle and a mouse that's given this drug to clear senescent cells. And you can see that when you clear senescent cells in the old mouse, there's an improvement in the spine bone volume fraction, as well as the other micro CT parameters. And this is associated with a reduction in the number of bone resorbing osteoclasts and actually no change in the bone forming osteoblasts. So this is in trabecular bone or cancellous bone at the spine. You see very similar findings in the cortical bone at the femur. So there's an increase in cortical thickness, and the femur is stronger based on the finite element modeling. And in the femur, there's a reduction in osteoclast numbers. And here we actually see an increase in osteoblast numbers and in the bone formation rate. So what you're seeing is that when you get rid of these bad senescent cells with aging in mice, you're reducing bone resorption or the breakdown of bone, and you're actually stimulating bone formation, both of which then lead to this increase in bone mass. Now, one of the other interesting things is that as we age, and these are human data from many years ago, with age, there's a reduction in the amount of bone. So this is a trabecular bone volume, and there's actually an increase in the amount of fat in the marrow adipose tissue. And so and this is also true in mice. So this is a young mouse, 8 months versus 26 months. And you can see here's the bone, but you can see this accumulation of fat in the marrow in the old mouse. So the question then is that with aging, you're getting both this reduction in bone and the increase in marrow fat. And is this in fact due to, again, a fundamental aging mechanism operating in bone and in fat? So when we went back and looked at the mice in which we had cleared the senescent cells, you can see that when you clear these, when you reduce the number of senescent cells, you actually get a reduction in marrow fat. So not only do you see an increase in bone, in these mice where you've gotten rid of the senescent cells, but you actually see a reduction in the marrow fat in these mice. And it really does say that senescence is contributing with aging, not only to this reduction in bone, but to also to this increase in marrow fat that we're seeing. Now, of course, you have to move from genetic studies in mice to drugs that can be used in humans. And for this, my colleague, Jim Kirkland, used an approach to try to identify drugs that might target senescent cells. And basically what they did is they used RNA sequencing to identify key pathways in senescent cells that were responsible for the anti-apoptotic effects or for keeping these senescent cells alive. And they found that this combination of dasatinib, which is clinically available, and quercetin, which is a flavonoid, that this combination selectively kills senescent cells in many tissues without affecting normal cells. And we actually showed in a accelerated aging mouse model that this combination of drugs, so-called senolytic, because they're killing senescent cells, actually improved lifespan and health span in these mice. So we went back to our mice and at 20 months treated them either with vehicle or with actually just once a month treatment with this dasatinib and quercetin, the senolytic combination, and essentially showed again the reduction in the senescent cells in different tissues. This is in fat. You can see the senescent cells are blue, and when you give the senolytic drug, these senescent cells disappear. Importantly, when we treated the mice with this combination, we found the same benefit as in our genetic model. So again, this is at the spine. When you treat with these senolytic drugs, you see this increase in bone in the spine. You also see the reduction in osteoclasts or the bone resorbing cells. Very similar findings to what I described earlier with the genetic model, an increase in cortical thickness, a reduction in osteoclasts in the femur, and an actual increase in the bone formation rate. So very similar effects, whether you use a pharmacologic approach here or what I described before, a genetic approach to get rid of these senescent cells. A third approach we used was what we call the Xenomorphic Approach, which is using a JAK inhibitor. And this is a clinically available JAK inhibitor that's used for the treatment of rheumatoid arthritis. And you can see when you treat the mice with the JAK inhibitor, you get very similar benefits. Now here, you're not killing the senescent cells, you're just inhibiting the secretion of their inflammatory phenotype, the SASP, and again, very similar findings at the femur. So what this study said was that in old mice that have established bone loss, 2 to 4 months of treatment with either a senolytic drug that will kill senescent cells or a xenomorphic drug that inhibits the secretion of the SASP improves bone mass, microarchitecture, and bone strength. The beneficial effect of targeting these senescent cells was due to a suppression of bone resorption with either a maintenance or an actual increase in bone formation. And then in studies I don't have time to get into, we showed how these senescent cells were affecting bone resorption and bone formation. And one of the important things is that if you give these senolytic drugs to young mice, you see no effect on bone. So the idea is that in young mice, you don't have many senescent cells. So giving drugs that kill senescent cells shouldn't have any effect. And that's exactly what we saw. It's only in old mice who have a high burden of senescent cells that when you give these senolytic drugs, that's when you see the benefit in terms of bone. Now, one of the interesting things is that senolytic treatment seems to be different from anti-resorptive treatment. So what I've shown you is that the senescent cells increase bone resorption and inhibit bone formation. So when you give a bisphosphonate like alendronate, it basically kills the osteoclast and decreases bone resorption. But because bone resorption and bone formation are coupled, you always get this reduction in bone formation with these standard anti-resorptive drugs. What we're seeing with the senolytic drugs is when you kill the senescent cells, you're reducing bone resorption, but you're actually also having a beneficial effect on bone formation. So there's either no change or an actual increase in bone formation. So you're getting this beneficial uncoupling between resorption and formation. Now, of course, we have to test this more in humans, but this suggests that by targeting, this cell, which is upstream of the osteoclast and the osteoblast, you might get more benefit than just directly targeting the osteoclast, because there you're indirectly also reducing bone formation. Now, let me move next to frailty. And one of the interesting things is that you can induce senescence in young mice. So these are young 6-month-old mice, which would be 30 to 35 years old in humans. And if you implant either non-senescent cells or cells that are made senescent using radiation, and we've labeled these cells so they stay in the abdominal cavity. So these young mice are injected with a fairly small number of these senescent cells. And you can see they're labeled with a marker, so they stay in the peritoneal cavity of the mouse. But they're localized to the peritoneal cavity. And you can see, if you look at one of these measures of frailty, which is grip strength, you can actually measure the grip strength of a mouse. That by giving as few as 500,000 cells, which is a tiny number of cells compared to all of the cells in the mouse, you could already see an effect in reducing grip strength in the mice. So even a very small number of these bad senescent cells given to young mice can lead to a reduction in muscle strength. And in data I don't have time to go into, we've repeated this experiment and show that when you give even a very small number of these senescent cells to mice, it actually causes bone loss also in the young mice. We also see in these mice, even though the cells are in the abdomen, when we look at the quadriceps muscle, there's an increase in these markers of inflammation and senescence. So what it's saying is that the senescent cells are actually secreting factors that go into the bloodstream and cause senescence in tissues that are far away, as far as the quadriceps muscle in this case. So what happens when you take old mice and treat them either with vehicle or the senolytic drug for 4 months? And you can see you can improve not only bone mass, but also frailty. So again, if you look at grip strength in the old mice as a measure of frailty, there's a significant improvement in frailty when you give these drugs that kill senescent cells, and a number of other measures. The other exciting thing was that not only do you improve frailty, but you also make the mice live longer. So following treatment, the control mice lived for an average of 140 days, whereas the mice that had the senescent cells killed with D plus Q actually lived 191 days. So at least in mice, clearing senescent cells is actually making them live longer. So in terms of frailty, what I showed you is that frailty is increased and lifespan is reduced by increased senescent cell burden, that if you clear senescent cells with senolytic drugs, you can reduce frailty and actually increase lifespan. And there's a feed-forward loop whereby senescent cells actually induce senescence even in distant tissues. So even though the cells were in the abdomen, they were actually inducing senescence in distant muscle tissue. So this has then led to the idea that as we age, there's an increasing senescent cell burden. So you go from youthful function to where you have various stressors like radiation, DNA damage that causes cellular senescence. And when you get to late middle age, there's enough of these cells that you start to develop all of these diseases that are associated with aging that then lead to frailty, sarcopenia, a decrease in health span, and eventually death. So the hope is that if you intervene at this stage and reduce the burden of senescent cells, that you can at least extend health span and maybe even prolong lifespan. So there are now at Mayo about 15 clinical trials that are underway. We have one that's looking specifically at skeletal health. So we're using in a pilot study in humans, This is registered in clinicaltrials.gov. Either D plus Q that we used in mice or fisetin, which is another senolytic drug. And we're testing over 20 weeks if we can favorably affect bone turnover markers. If this study is positive, then we will plan longer studies. But there are also other studies looking at frailty, at chronic kidney disease. It turns out that senescence may actually play a role in post-COVID and in the recovery from COVID. So there's a lot of, because the COVID-19, the virus itself seems to induce senescence in lung and in other tissues. So the thought is maybe clearing those senescent cells might prevent some of the long haul symptoms that people are getting from COVID. There's also evidence that these drugs may have some efficacy in Alzheimer's. So this is just a small example of the many, many studies that are now being initiated by investigators, not only at Mayo, but in private companies and many other places. Now, of course, there are always concerns. So one concern is cancer. And this comes from the idea that senescence probably evolved as an anti-cancer mechanism. So when a cell developed DNA damage, instead of becoming a cancer cell, it became senescent and growth arrested. So it was better for the organism to have a senescent cell rather than have cancer. And there's probably some concern here. But one of the important points is that the senolytic drugs are effective when given intermittently, so maybe only once a month. So these drugs only periodically reduce the burden of senescent cells, and they don't really prevent them from forming in the first place. And there's also evidence that once you have cancer, senescent cells, because they have this pro-inflammatory SASP, they actually make the cancer grow faster. So while inducing cancer is a concern with clearing senescent cells, I think there are strong arguments that indicate that that's likely not going to be the case. But of course, we have to test that in the human studies that are ongoing. Another concern is development and wound healing. Now, it turns out that during embryonic development, there's actually programmed cell senescence that occurs in various tissues. Relevant to bone, there's cell senescence that occurs in the primary spongiosa of long bones. So part of the fusion of the growth plate actually involves senescence of progenitor cells. And then it turns out that senescence may actually be important in wound healing in the skin. And this is work that I'll just show you. So this is a different genetic model. It's not important what it is, but this is a skin wound and the size of the wound and the healing. And so to keep it simple, if you look at the blue time course, which is here, and the orange, which is mice in which the senescent cells using a different approach have been removed, you can see that in the skin, if you remove the senescent cells, you actually delay wound healing. And based on this work, the investigators postulated that in injury, that there are cells that become senescent that actually are important in healing the wound through the secretion of various cytokines, in this case, PDGF alpha, so that when you clear these senescent cells, you actually got a delay in wound healing. Now, this, of course, is a concern that if you have tissue injury and these senescent cells appear during injury, that if you get rid of those cells, are you going to impair healing? So we were very concerned about this and looked at the issue of fracture. So this is a paper that we just published recently on the effects of clearance of senescent cells during fracture using the senolytic combination of D plus Q. So this is the design of the study. You can see the mouse. This is a mouse study where they undergo fracture and then they're treated intermittently with D plus Q. We showed that the D plus Q treatment actually cleared the senescent cells. Well, first of all, we showed that with fracture, there is a transient accumulation of these senescent cells at the fracture site. And the D plus Q actually cleared these cells. And that's shown here because some of the markers of senescence were reduced when you treated the mice with D plus Q. But in contrast to the skin, we actually found that in fracture, when you cleared the senescent cells, there was actually an improvement in fracture healing. So this is the callus area, this is the control mice, and this is the DQ treated mice. So you can see by 3 weeks, there was actually more callus in the mice that had the clearance of the senescent cells. And this is just quantitated here. We also used micro-CT to quantitate the callus bone volume, and that was actually better when you cleared the senescent cells. And in fact, using biomechanical testing, at the end of the 5 weeks, the bone was stronger when we had cleared the senescent cells. So this was in young mice. So even in young mice, you get this transient accumulation of senescent cells. And if you clear those cells, you actually seem to improve fracture healing. So what these studies said is that senescent cells actually accumulate in the fracture callus. They also accumulate in the skin when you injure the skin. But in contrast to the skin, clearance of senescent cells in bone does not impair, but actually improves fracture healing. And obviously this has clinical implications for the development of senolytic therapies for osteoporosis, because if you put patients with osteoporosis on these type of treatments, and these treatments are going to delay fracture healing, obviously that would not be a good treatment for these patients. But I think our data would indicate that it may actually help fracture healing. But this is also important biologically because the concept that senescent cells always facilitate healing may not be true, because the beneficial versus detrimental effects of senescent cells on injury repair likely vary across tissues. It may be different in the skin versus in the bone. So before you start taking senolytic drugs, what are some of the factors that modulate senescence? So we know from many mouse and human studies that obviously aging increases senescent cells. A high-fat diet actually increases the number of senescent cells in many different tissues: physical inactivity, smoking, chemotherapy, radiation, chronic HIV infection. So avoiding as many of these insults as possible is one way as we age to prevent the accumulation of senescent cells. The other is exercise. There's good evidence now that physical exercise actually reduces the burden of senescent cells across tissues, and caloric restriction, it turns out, also is another way to reduce senescent cell burden. These are actually 3 human studies that were summarized in a meta-analysis, and they actually looked at exercise effects on P16 levels as a marker of senescence. And you can see overall, with exercise, there was almost a 40% reduction in senescent T cells in these studies. So this is direct human evidence that exercise, in fact, has a beneficial effect in terms of reducing senescent cell burden. So I'd like to close by acknowledging many people in my lab, Josh Farr, David Monroe, collaborations that we have with other labs in the Aging Center, the Kirkland Lab and others, and then collaborations we have with the University of Minnesota and investigators at Scripps and San Antonio, funding that we get from NIH, from National Institute of Aging and other foundations. And I think I've left time, so if people have questions, I'm happy to take those.
Todos son bienvenidos a hacer preguntas por el chat, a compartirlas si las tienen. Doctor Olarte.
Sí, listo. Vamos a ver si alguien tiene una pregunta por el chat.
Acá tengo una pregunta y es, en una de las gráficas nos mostraba que en ratones las hembras parecen tener menos células senescentes durante el envejecimiento. ¿Se conoce cuál es el efecto de la señalización por estrógenos en la senescencia? ¿Y tienen los anticonceptivos algún papel en la modulación de la senescencia en el hueso u otros tejidos?
Yeah, that's a good question. So with aging, we see an increase in senescent cells both in female mice and in male mice. And there are other human studies that show that senescent cells go up with aging in both sexes. There is some evidence to suggest that it may be more accelerated in males. Exactly why that is, we haven't sorted out as yet. We do know that if we do ovarectomy in young mice, that we can't prevent that bone loss due to estrogen deficiency in young mice with senolytic drugs. So senescence and estrogen deficiency seem to be working, at least on bone, through different pathways. But whether with aging there's a sex difference, there may well be, and that's an area that many different groups are looking at.
Ok, muchas gracias, doctor. Tenemos aquí otra pregunta. ¿Existe alguna relación entre la actividad física y la carga mecánica en el hueso y la senescencia? En situaciones de baja gravedad o reposo prolongado donde existe pérdida de densidad mineral ósea, ¿existe un aumento de células senescentes?
Yeah, that's a very good question. So the question really gets at the interaction between mechanical loading in bone and the accumulation of senescent cells. And, as you know, when animals or humans go up into space, there's a lot of bone loss. And we don't know if that's due to an increase in senescence, but there are a number of groups that are examining that. Our group actually is interacting with NASA to see if some of the bones that come back from animals that have been in space flight, that we can assess whether there's an increase in senescent cells in the loss of gravity. And there are other groups that are doing here on Earth, unloading studies in mice to see if you unload the bones of the mice, do you get an increase in senescent cells? So the interaction between gravitational effects on bone and senescence, I think, may well be there. We just don't have the actual data as yet.
Ok, muchas gracias. Aquí hay una pregunta en el chat de la doctora Amparo Gómez. ¿Hay otros factores que puedan disminuir las células senescentes que puedan implicar cambios en hábitos de vida?
Sorry, could you repeat the question?
¿Hay factores que puedan disminuir las células senescentes que puedan implicar cambios en los hábitos de vida? O sea, si los cambios en hábitos de vida pueden disminuir las células senescentes, ¿y cuáles de estos cambios de vida podrían hacer esto?
Yes. Yeah. So as I mentioned, the two main factors that appear to be effective at reducing senescent cells, both in animal and now there's animal and human data. So one appears to be exercise. So physical activity through mechanisms we don't fully understand. Some of it may be loading, as was asked about earlier. So exercise does seem to reduce senescent cell burden. In fact, in animal studies, if you give them if you give mice a high-fat diet, they accumulate senescent cells across many different tissues. But if you give them a high-fat diet and exercise them, you could actually prevent the increase in senescent cells by exercising them, despite giving them a high-fat diet. The other maneuver that seems to reduce senescent cell burden is caloric restriction. So as you may know, there are many studies looking at the effects of modest caloric restriction on enhancing lifespan, and some of that effect could well be due to reducing senescent cells. Now, there are other factors that increase senescent cells, so exposure to radiation, chemotherapy, smoking. So avoiding those factors that make more senescent cells is also important in terms of lifestyle. So I would not advise at this point taking senolytic drugs. You can actually buy, fisetin or a D plus Q from, well, D, you have to get a prescription, but Amazon actually sells fisetin and quercetin. But I would advise against taking those drugs because we just don't know the long-term effects. but I think certainly the lifestyle measures like exercise and moderating calories would be important in terms of reducing the number of senescent cells.
Gracias, doctor Clausura. Hay aquí una pregunta.
Tu sonido, Carlos, se perdió tu sonido.
Ups, perdón. Hay una pregunta aquí que le pregunta al doctor Clausura, más allá del desatinib y queracitin y el fisotin, ¿cuáles son más específicos en sus mecanismos y qué agentes están investigando más específico hacia el P16 y el P21, hacia la vida del P16 y el P21?
Yeah, so as I understand, the question is more, whether you can target the P16 or P21 pathway more directly in terms of affecting senescence. The drugs that we have are downstream of that, so they target the anti-apoptosis pathway. And the reason for that is that P16 and P21 are actually also present in normal cells. So if you target those pathways directly, you're likely to have other adverse effects in different tissues. So the drugs that are being developed are basically targeting the survival pathways that are relatively specific for the senescent cells. So using that mechanism, you can kill the senescent cells without affecting the non-senescent normal cells.
Y una última pregunta que tenemos acá es acerca de si el consumo de antioxidantes o ácidos grasos omega 3 son útiles para disminuir el número de células senescentes en el hueso.
I think I had trouble hearing the question. Maybe you could...
Sí, si el consumo de antioxidantes o ácidos grasos omega 3 tiene algún efecto en el número de células senescentes en el hueso.
Yeah, that has not been looked at directly. I mean, you would think because oxidative stress is one of the triggers for cell senescence, that the consumption of antioxidant drugs would presumably reduce senescent cell burden in bone or in other tissues. But in fact, I'm not aware of studies that have directly looked at that. And that work certainly needs to be done.
Y tengo una última pregunta para ya terminar y cerrar la sesión. Y sería, nos pregunta Andrés Rico, ¿qué tan lejos en el tiempo están este tipo de senolíticos de llegar a estudios de fase 3 o a la comercialización para su uso en humanos?
Yeah, that's a big question. What I can tell you is that there are many phase 2 studies now that are looking both at safety and efficacy. These are short-term studies, 1 month to 3 to 4 months. And I think I would say in the next 2 years, we should have data on the efficacy of these drugs. There are companies, in addition to Mayo and other medical centers, there are many companies that are pursuing these drugs and different versions of these drugs. So assuming that we don't encounter unforeseen side effects and we can demonstrate efficacy, I would say, in the time frame of about 5 years, we should be hopefully nearing completion of, at least the first phase 3 trials of these drugs.
Una persona, Gabriel Ayala, está muy interesado en la creatina, que se promociona mucho para mejorar la calidad de la función muscular. Y él nos pregunta si la creatina tiene algún efecto en la calidad de la función ósea.
No, I'm not aware that creatine, I know it's used quite a bit, but I'm not aware of any beneficial effects of that on bone or on senescence.
Muchas gracias, doctor Kozla. De verdad es para nosotros un honor que usted nos haya podido acompañar en el cierre de este curso. Su charla fue fenomenal y nos permite ver cuál es la frontera del conocimiento de la investigación en envejecimiento, en especial para un tema tan importante como el de la osteoporosis. Varios investigadores en Colombia están tratando de trabajar temas en envejecimiento. Nuestra universidad está trabajando temas relacionados con la aterosclerosis y su relación con la calcificación ectópica. Entonces esperamos poder establecer puentes y colaborar con ustedes en este muy interesante campo de investigación en el corto plazo. Muchas gracias por acompañarnos. No sé si quiere tener algunas últimas palabras para despedirse, doctor Kozla.
Sure, no, it's a pleasure to visit with all of you virtually, and I appreciate all of the many participants. I see there were a lot of participants in the meeting, so it was great to visit, and I think generated a lot of interesting questions. So thank you for the questions that you all asked.
Muchas gracias, doctor Kozla. Vamos entonces a continuar con la programación del evento. Entonces, ahora vamos a escuchar unas palabras de Daniela Abril, quien es nuestra directora de pregrado. Daniela, ¿estás por acá? Creo que tuvo un problema de conexión, porque la vi conectada, pero no está acá.
Sí, si quieres, pasemos entonces, mientras tanto. ¿Aló? ¿Sí está Daniela?
No, creo que no. Entonces, si quieres, Nubia, ustedes saben que este curso no se hubiera podido realizar sin el apoyo del laboratorio Amgen. Entonces, Nubia, te damos la bienvenida para que puedas también comunicar cómo te pareció el curso y tus impresiones a futuro acerca de este tema interesante.
Doctor Peña, doctor Olarte, a todos los profesores, mentores institucionales y por supuesto al doctor Kozla, muchísimas gracias. El balance es absolutamente positivo, digamos, uno de los imperativos estratégicos de Amgen en el área terapéutica de hueso es seguir previniendo las fracturas por fragilidad y bueno, como ustedes saben, todo este programa ha sido encaminado a que ese paciente que les llegamos tarde desafortunadamente, que ya se fracturó, se le puede evitar una segunda fractura por fragilidad. Y este interés, digamos, que vimos en cada una de las sesiones sincrónicas de cada uno de ustedes, su participación, pues nos motiva mucho a seguir fomentando estas actividades académicas con el apoyo de instituciones tan reconocidas como la Universidad de los Andes, la Fundación Santa Fe de Bogotá. Y realmente la retroalimentación que hemos tenido de nuestros médicos también ha sido positiva. Y esperamos que cada uno de ustedes y dentro de sus instituciones de verdad se empiecen a fomentar y a formar grupos de prevención secundaria de fracturas, que es el objetivo, digamos que más grande de este evento académico, de este curso virtual de FLS que tuvimos a lo largo de este año. Y bueno, mis más sinceros agradecimientos a todos los que hicieron un esfuerzo, porque sabemos que en este contexto de la pandemia, el tiempo, la familia, bueno, eran factores muy importantes que tampoco se pueden quedar atrás, pero muchos de ustedes hicieron el esfuerzo por conectarse siempre, por hacer los talleres, las preguntas, las evaluaciones. Entonces, de verdad que un agradecimiento en nombre de todos esos pacientes que se van a ver afectados positivamente por su interés académico y todo el juicio que ustedes le han puesto en esto. Desde el Departamento Médico de Amgen, por supuesto, las puertas quedan abiertas para cada uno de ustedes que quiera seguir contactando con nosotros para más actividades académicas enfocadas a la prevención de fractura. Y bueno, un agradecimiento, doctor Peña, de verdad que cerramos, yo por mi parte cierro con un balance muy, muy positivo y muy feliz de los resultados que se obtuvieron. Muchísimas gracias.
Nubia, muchas gracias. Muchas gracias, Nubia, y muchas gracias al laboratorio Amgen por el apoyo, como dice Ricardo, para estas actividades. Creo que vamos a hacer otra actividad, entonces pues muchas gracias y vamos a quedar en contacto. Ahora le vamos a pasar la palabra a Ana Milena como
como coordinadora del curso, en nombre de los coordinadores, va a dar unas palabras. Ana Milena.
Hola, muy buenas tardes. Creo que tengo inactivo el video, pero voy a irles comentando un poco pues, cómo fue este proceso para nosotros los coordinadores. Nosotros fuimos llamados pues, por la Universidad de los Andes a generar el contenido de este curso, el cual pues desarrollamos con bastante interés, basado en la mejor evidencia que hay actualmente sobre la prevención secundaria de fracturas, en nuestra experiencia también como centro, y queríamos a todos ustedes pues transmitirles un poco de ese conocimiento y transmitirles de la mejor manera nuestra experiencia. Creo y estoy convencida también, como lo han dicho los demás profesores, que esto ha sido un curso exitoso. Hemos recibido muy buenos comentarios de los estudiantes. También les pedimos que por medio de su plataforma nos hagan llegar toda la retroalimentación de las cosas que ustedes mejorarían, porque estamos en búsqueda de seguir creciendo y pues que este curso no termine acá. Mil gracias y se los he dicho por esas sesiones sincrónicas. Creo que fueron demasiado y fueron muy enriquecedoras para todos, no solo para los estudiantes, sino para los que fuimos docentes o coordinadores. Se dieron unas discusiones de altísimo nivel académico y fueron unos debates muy interesantes cada una de las noches de jueves que estuvimos reunidos. El tiempo, alcanzar en medio de pandemia y en medio de un cansancio colectivo por la virtualidad, días de 120, 180 personas conectadas al mismo tiempo, haciendo preguntas, interesados en ese aprendizaje, para nosotros es completamente satisfactorio y nos hace muy felices haber tenido esa respuesta por parte de ustedes. Entonces, agradecimientos, muchísimos agradecimientos para Amgen por su interés en este curso, a la Universidad de los Andes por este gran esfuerzo de tener que coordinar a esta cantidad de docentes y profesores que sabemos que a veces no es una labor fácil, a los docentes que amablemente estuvieron acompañándonos no solo en las sesiones sincrónicas, sino también en la grabación, por estar pendientes a cambiar cosas, a corregir, a estar atentos. Muchas gracias a ti, Ricardo, por ese apoyo tan importante que nos has dado. Y pues por último, gracias a los estudiantes porque nos sentimos confortables totalmente con todo el aprendizaje que hemos obtenido, con la respuesta, con los comentarios, con su unión a cada una de las sesiones. Entonces, una feliz noche y creo que seguirá otra parte del programa antes de finalizar y mil gracias.
Ana Milena, muchas gracias y me uno a tus palabras y muchas gracias. Y esto es en nombre de no solamente los coordinadores, sino todos los faculty, los agradecimientos nuevamente a Amgen, a la Universidad de los Andes y a todos los que hicieron posible pues, este curso. Ahora vamos a oír a uno de nuestros participantes. Entonces el doctor Andrés Livos muy gentilmente se ofreció a comentar sobre su experiencia en el curso. Doctor Livos. Le damos contacto al doctor Livos, por favor.
Hola, buenas tardes. ¿Me escuchan?
Sí, puede encender su cámara.
Sí, sí, por supuesto. Que no me deja que porque el host has disabled.
¿Qué pasó?
Que no me han dado permiso para prender la cámara.
No importa, no importa. Entonces cuéntenos.
Bueno.
Andrés.
No, buenas tardes a todos. De antemano, pues quisiera agradecer a todo el mundo por por el programa, por las clases sincrónicas y asincrónicas. Siento que este tipo de modalidad empezó a gustar bastante bien a que la gran mayoría de las personas pudieran conectarse, tener el material estudiado para que en las conversaciones asincrónicas fueran muy didácticas. Y la verdad, siento que las sesiones asincrónicas, el material educativo, excelente, muy completo, la verdad, pues ha ayudado bastante tener esas evaluaciones para poder medir si uno comprendió bien o no el material, y siento que las sesiones sincrónicas para poder fomentar todo lo que uno aprendió en las sesiones asincrónicas fueron de gran utilidad, y pues creo que eso fue lo mejor de todo el curso. Esas discusiones entre los docentes y ponentes, donde pues toda la información que tienen pues es bastante y es pues inmensa, que lo fortalece a uno con sus conocimientos para pues tener mayor claridad en todos los aspectos que uno aprendió durante el curso. Entonces, muchísimas gracias a todos.
Gracias, doctor Livos. Y en este momento quisiéramos mostrar nuestro diploma, el diploma que ustedes van a recibir más o menos 5 días después del curso. Este es el diploma que van a recibir ustedes en nombre de la Facultad de Medicina, la Dirección de Educación Continuada y la Fundación Santa Fe de Bogotá. El diploma para el posgrado de creación de centros de prevención de fracturas FLS. Es un orgullo para la fundación y para todos nosotros poder entregarles a ustedes este diploma, que lo van a recibir 5 días después de que ya se complete todas las cosas para ver que todos hayan aprobado el curso. Y les agradecemos infinitamente su paciencia, que se hayan conectado, a los faculties, a la universidad, a los participantes especialmente, que sin ellos no se hubiera podido hacer este curso. Muchísimas gracias. No sé si ya se conectó de la Universidad de los Andes. Ricardo.
No, creo que tuvo una falla Daniela, que es nuestra directora de pregrado, pero voy a tomar entonces la palabra en la facultad. Para nosotros es muy importante este tipo de actividades, porque por mucho tiempo se ha visto de pronto una desconexión de la academia, que ve el mundo desde lo ideal, y el mundo real, que es el que están practicando ustedes a nivel de los centros hospitalarios, y ustedes que son quienes están atendiendo a los pacientes. Entonces, este tipo de oportunidades que nos permiten realmente conectarnos, integrarnos, escucharnos, aprender de la discusión, porque al final el aprendizaje no es algo que existe, es algo que se construye cuando nos escuchamos, cuando hacemos preguntas y cuando tenemos la oportunidad de aprender de la experiencia de expertos, como tuvimos hoy el doctor Kosla. Entonces, de verdad, les damos gracias a todos por haber confiado en nosotros. Ustedes durante este curso fueron parte de la familia uniandina. Veo que hay bastantes preguntas en el chat, especialmente relacionadas con logística del curso. De pronto puedo intentar responder algunas de ellas. En cuanto a la grabación de la sesión está quedando grabada, está quedando en YouTube. Entonces le voy a pedir el favor a nuestro equipo de educación continuada para que les coloque en el chat el enlace para que ustedes lo puedan compartir. También ese enlace se los enviaremos a través de un correo electrónico. Algunas personas están preguntando por la vigencia de las clases en el curso. Las clases no se pueden mantener abiertas por todo el tiempo. Sin embargo, vamos a intentar de pronto que estén abiertas por un par de semanas para que ustedes puedan repasar. No se los prometo, pero vamos a hacer el mayor esfuerzo por lograrlo. Entonces vamos a trabajar con nuestro equipo de educación continuada, y seguramente el día de mañana o a más tardar el jueves recibirán un correo detallando hasta cuándo van a tener acceso a la plataforma para que tengan acceso a los videos. pero de nuevo ha sido un gusto contar con la participación de todos ustedes. Muchísimas gracias, Ana Milena, muchísimas gracias, Carlos, porque ustedes lideraron el trabajo para que este curso pudiera ser un éxito. Ellos ayudaron a armar el equipo de docentes que presentaron los materiales que todos los estudiantes revisaron a lo largo de esta semana. Gracias al equipo de educación continuada, gracias al equipo de diseño que trabajó en los materiales, y pues esperamos continuar trabajando con ustedes en futuros cursos, sea en nuevas versiones de este curso de fracturas o en otros cursos que les va a ofrecer la Universidad de los Andes. Muchas gracias a todos y creo que con esto podemos terminar. Que tengan una excelente noche, que pasen un buen tiempo con sus seres queridos. Gracias a todos.
Gracias, Ricardo. Muchas gracias. Nos despedimos entonces con las palabras de Ricardo y muchas gracias a todos por asistir.
Feliz noche. Gracias, gracias.
Gracias a todos. Una feliz noche.